Welcome to our 9th episode of Marvelous Medicine that we have every Thursday on Zoom. And today's topic is on intraoperative neuromonitoring. Called it primum non nocere, how to make neurosurgery safer. We didn't think we would have enough time to discuss everything about all types of intraoperative neuromonitoring. So we've decided to restrict ourselves. The talks will be restricted to the neurosurgical and spine applications, but the discussions we will try and include all the other surgeries for which we can do intraoperative neuromonitoring. So it gives me great pleasure to introduce Nitin Manohar. He's a specialist anesthesiologist at Burjeel Hospitals in the Emirates. He did his MBBS from Mysore Medical College and MD Anesthesia from JJM Medical College, Davangere. His DM Neuroanesthesia from NIMHANS. As far as India is concerned, the Mecca of neuro anesthesia. And he was working as a consultant in charge for neuroanesthesia in Yashoda Hospitals in Hyderabad, which is actually a very busy neurosurgical center. He has 30 publications and he's written 5 book chapters. He's a reviewer for various journals, and he's also conducted workshops and has spoken in various conferences. I met Nitin accidentally. Pre-COVID, I used to travel to demonstrate the low-flow anesthesia to various hospitals and medical colleges. And what really impressed me was the utter humility and the eagerness to learn. Though he's a big shot anesthesiologist, but he was so keen to learn, and I could see the passion with which he teaches his juniors. So welcome. I couldn't think of anyone better to do this talk. So welcome, Nitin. Most of our episodes have been, previous episodes, the speakers have been 40 or 50 plus. I thought it was time that we got some young people into the picture. So I zeroed in on Kanchan because she's a JIPMER alumnus. That's how I found her. She's a junior consultant at Vikram Hospital, Bangalore. She's also had pretty much the same route like Nitin, MBBS in Mysore, MD in JIPMER, and then DM in NIMHANS. Though she's fairly junior, she already has 6 publications, and she's looking out to do fellowship to specialize even more. So I guess she's the antithesis of me. I try to avoid exams, and Kanchan loves taking more exams. And Kanchan, even if you try very hard, you cannot beat Shyam, who is our moderator today. Currently, technically he's associate professor of Department of Biomedical Informatics. Am I right, Shyam?
Yeah.
At Pittsburgh. But there's nothing that he hasn't done. He did his MBBS from JIPMER. He's a few years junior to me. Part of his anesthesia training, and then decided to switch to basic sciences and did his master's in physiology and biophysics at Illinois. Then he started his medicine residency and went on to complete his neurology training in Boston. So there is after that, Shyam will tell you about what else he's been up to. But other than all this, he's very much interested in music. He used to be very active in our Speakmake at JIPMER. He also single-handedly created the JIPMER net long before Facebook and Google and anything else was there. He started an alumni thing on the net, because of which all JIPMERites across the world could be connected. In between, due to privacy issues, it had to be taken down, but now he's again worked hard to try and get it up again. So thank you, Shyam, for keeping us all connected. And despite the time difference and his various other commitments, as soon as I suggested that he should moderate on this session, he joined in. And his passion is artificial intelligence, and soon in one of our upcoming episodes of Modern Medicine, we will try and get Shyam to speak about how to apply artificial intelligence in anesthesia and surgery. So with these words, over to you, Nitin.
Thank you, madam. Thank you for that kind introduction. And I consider it a great honor to be amongst all of you. I mean, I have all my seniors there, and it's the variety of people sitting and listening there. I consider it a great honor. Thank you, Dr. Vidya. And I'll try to do my best with this topic in the limited time. I'll start sharing my screen. Can you see my slides, madam?
Yes.
Yes.
Yeah. Thank you. Good evening, one and all. And I'll be talking about the principles of intraoperative neuromonitoring today. So in a 20-minute span, I don't think I can explain how it is done and the technicalities about it. This will be just like a primer lecture to introduce you the concepts and how it is used in clinical practice. Dr. Kanchan has a lot of cases that she will show you. I'll just try to touch upon the various modalities that are used in neurosurgery and across other surgeries as well. So this is Professor Penfield. He started doing intraoperative neuromonitoring, way back in the early 1900s, where he used to stimulate the brain and then look for responses during his neurosurgeries. He was the first person who started this, and then the way he has shown us the way how we can do intraoperative neuromonitoring and do surgery safely. The principle of today's intraoperative neuromonitoring is the same Hippocratic oath that we all took. That is, first do no harm to the patient. So as we remove tumors, as we remove lesions from brain and spinal cord, we don't want to create harm to the patient. So this is the same principle that intraoperative neuromonitoring works on. So neurosurgery has evolved from an era of an anatomical concept, that is to remove the total tumor in bulk and then to have a clean scan post-operatively, to an era where we want to have maximal safe resection, where an anatomical and a physiological concept has come in. So we want to do maximal resection, but safely. So we want to give the patient a good functional outcome after the neurosurgery as well. So this is where intraoperative neuromonitoring has come in. So just to tell you that there are various adverse events and errors that can happen in medical practice, but what intraoperative neuromonitoring focuses on is those unexpected or dangerous events which can be caught in time, so that there is not a permanent, so that there is no permanent harm created to the patient. So this is where intraoperative neuromonitoring comes in. So this paper is very interesting. I always show this slide because in the last 50 years, they have studied the various innovations that have happened in neurosurgery, and you can see intraoperative neuromonitoring along with image guidance. These are the most influential areas where neurosurgeries have evolved. So initially the microscope came in, then the endoscope came in, and then all this DBS stimulation and all those neuromodulation devices came in. But intraoperative neuromonitoring and image guidance, these two are the areas where neurosurgery has tremendously evolved, and that's why our neurosurgery today is considered safer, and people who don't have to be afraid whenever they have a cranial or a spinal lesion to come into an operation theater. These are the various publications that have been published in the last few years, and if you look at it, neurophysiological monitoring has got a lot of interest, and a lot of research is happening in this field to make neurosurgery safer. So what is intraoperative neuromonitoring? Intraoperative neuromonitoring is nothing but monitoring neural pathways when a neurosurgery is being performed. So the surgeon performs the neurosurgery, the neurophysiologist or the person doing the neuromonitoring continuously monitors the neural tissues so that the normal neural tissues are not damaged. That is all that intraoperative neuromonitoring what we do. Today's era is of multimodality IONM. We don't do one modality for one surgery. We try to do a lot of things around the area that the surgeon is operating so that we get information from various tissues and so that the patient is kept safe. So at the end, we want a deficit-less surgery. The patient should wake up without a neurodeficit and the tumor should be maximally removed. For this, there are two things that we need to, the intraoperative neuromonitoring, needs knowledge of. One is the physics, which we, I think, forgot at our +2 stage after we joined medicine. A lot of us, physics is something which we are not very good at. Intraoperative neuromonitoring requires us to understand physics so that we can apply it on our medical patient. The second thing is the physiology, which probably after the first year of MBBS, we all, kind of sidelined it back, and then we don't give importance to these two together. Combinedly, you have to have good knowledge to do good intraoperative neuromonitoring. So like I said, the objective of intraoperative neuromonitoring is to prevent a permanent injury. So the injuries during neurosurgery can be of various types. It can be mechanical, when a surgeon directly handles a tissue, he does retraction on the brain. It can be vascular when there is a clamp applied on the carotid during a carotid endarterectomy, or when there is a vasospasm of an arterial territory going on. It can be positional because of a long duration surgery when the brachial plexus is going to be injured. So you can monitor the brachial plexus. It can be physiological, like hypotension can cause ischemia to the tissue and then harm the tissue. So all these iatrogenic injuries can be monitored with intraoperative monitoring. And the main advantage of doing intraoperative monitoring is that even if you have a signal change on your IONM recording, you still have time to intervene when you can reverse the ongoing damage and prevent a permanent injury. So it is a reversible injury which can be prevented to becoming a permanent injury. That's the whole crux of intraoperative neuromonitoring. So now there are various signals that we capture intraoperatively. One is the evoked potential. So what do we mean by evoked potential? Evoked potential means you stimulate one tissue or one area and then you evoke a response at a distant site. You measure for the response that is coming from the distant site, and this is what is called as evoked potential. So you are evoking a response. There are some signals which are free running as well, like your EEG of the brain, okay, like your muscle electrical activity, like your EMG. These are spontaneous signals. So they can be the IONM can be classified into evoked and spontaneous responses. To do intraoperative monitoring is challenging, and there are a lot of physics involved in this, and a few of the concepts that are involved. I'm not going to go into too much of technical details. The thing is, the evoked potentials that we record are very, very small. If the ECG is 1000 microvolts, if EEG is 100 microvolts, the evoked potentials that we record is 1 microvolt. So it is a very, very small signal. We need to amplify the signal. And then there is a lot of electrical noise going on in the operation theater with various electrical devices. So for these noise to be removed, we need to average the signals and also do noise reduction by referencing and by grounding. So these are the main concepts which are involved in getting a good signal. So like I said, the responses can be divided into spontaneous, that is the free running. Just like our heart doesn't stop, the brain doesn't stop as well. There is electrical continuous activity going on, which can be captured with EEG. The muscle also has an inherent electrical activity going on. This is called as EMG or electromyography. And then the second type is the evoked response based on what you're evoking, by what your stimulus you're giving. So in visual evoked potentials, you give a visual stimulus to the eye and you evoke a response in the occipital cortex. In auditory evoked response, you give auditory clicks to the ear and evoke a response from the temporal lobe. In sensory evoked potential, you stimulate the peripheral part of your limbs and then you give through electrical current and evoke a response in your sensory cortex. So these are sensory evoked potentials. The other way around is the motor evoked potentials, where you stimulate, if you can stimulate the cortex of the motor cortex in the brain and evoke a response in the muscle, this is called as motor evoked potential. If you stimulate a nerve and then record a response which is triggered in the muscle, that is called as triggered electromyography or triggered EMG. So this is a whole array of intraoperative neuromonitoring techniques that we use during neurosurgery. Some basic terminologies for people who are interested. I thought I'll just tell you the basic concept. This is how a evoke response can look like. So this is where we have stimulated. This x-axis is the time. So how late the response is coming. So this is the response. This is the peak. This is the trough. So how late the response is coming. This is called as latency, or this is the conduction time. So any prolongation of latency or increase in conduction time also can be a signal that there is some ongoing damage going on. The second thing is the amplitude. Amplitude means how big is the response. From the top of the hill to the deepest part of the valley, from the peak to the trough. This is called as amplitude. So any amplitude reduction can also signify an ongoing neural injury. So what we see in intraoperative neuromonitoring is only two things: amplitude, that is how big is the response, and latency, that is how late the response is coming. So the whole intraoperative neuromonitoring, these terms you will be hearing, that is amplitude, latency, amplitude, latency. So this is how an intraoperative SSEP monitoring waveform looks like. Here you can see the red one is the baseline that we have acquired at the starting of the surgery when the surgery has not been started. These green ones are the average signals which have been acquired, and the white one is the ongoing averaging, which we are trying to get a signal now, at this point when the surgery is going on. Some basic concepts. So whenever you do intraoperative neuromonitoring, what we do is we take a baseline recording under steady state conditions. That is under steady state of anesthesia, under steady state of hemodynamics, under steady state of homeostasis. We take a baseline recording and then we continue to do the neurosurgery. And when there is a critical step of neurosurgery going on, we compare the ongoing signal then with the baseline. So that's all. And what we compare is the latency and the amplitude. So latency, amplitude, compare it with the baseline recording when you have not yet started the surgery, and then look for any increase in latency and decrease in amplitude. That is what we look at. Then there are alarm criteria. The alarm criteria is different for different evoked potential monitoring. So I will not go into detail. The general rule is a 10% increase in latency and a 50% decrease in amplitude is considered an alarm criteria. This is a general dictum, but it does not hold good for every monitoring modality that we use. The another concept is a control. Control means monitoring of something away from the area of interest. So if you're doing a lumbar surgery, area of interest is lower limb. What we do is we keep a control in the upper limb as well. So how it helps us to differentiate if it is a real surgical injury that is causing a decrease in signal, or there is a global decrease in signal because of various factors like anesthesia, hypotension, hypothermia. So this control concept is also very important. These are the basic concepts in intraoperative neuromonitoring that we use. This is the equipment that we use. This is a monitor. These are the boxes, and these are the needles, the electrodes that we use to place in the muscles. These are the corkscrew electrodes which are placed on the scalp. These are the stimulators which the surgeons use during the intraoperative period to stimulate the brain and the nervous tissue. There are various neurosurgeries that can be performed with intraoperative. The list can keep going on. Wherever you have a neural tissue and there can be a damage, you can do intraoperative neuromonitoring. But these are probably the neurosurgeries where you have to kind of mandatorily do intraoperative monitoring, like intramedullary tumors of the spine, CP angle lesions, brainstem gliomas, spinal dysraphism. So these have enough evidence. These cases you have to kind of mandatorily do intraoperative neuromonitoring and do these neurosurgeries in today's era. So many people ask this question: what is the level of evidence? So do you have evidence, to compare whether if you do a surgery with or without intraoperative neuromonitoring, what is the difference? The example that I can give you is: will you wear a seat belt or not when you drive? So the choice is yours. If you don't wear a seat belt, you might not have an accident, but it's always better to have a seat belt and go into driving. So that's how it is for all neurosurgeries. Whenever there is a high risk neurosurgery, it's like jumping off a plane. Will you ever jump without a parachute? I don't think you need any evidence or any comparison here to do a randomized control study. So for high risk neurosurgeries, intraoperative neuromonitoring has become a standard of care. Usage by neurosurgeons. There are various stages through which a neurosurgeon evolves in his career, but intraoperative neuromonitoring will help in all phases of the career. So initially, when a budding neurosurgeon starts his work, he can use intraoperative neuromonitoring to assess whether his surgical techniques are correct, whether he's retracting the brain properly, whether he's handling the tissues gently. So this helps the budding neurosurgeon. For an experienced neurosurgeon who has learned his neurosurgical skill, he will not use it for normal, general cases. He will use it only for a high risk neurosurgical procedure where there is a high risk for neurodeficiency. So neurosurgeons across their, through their career can use intraoperative neuromonitoring for their practice. This was one thing which we collected data on in India. This was 3 years back, when intraoperative neuromonitoring had started to, it was the early days of intraoperative neuromonitoring. You can see that the intraoperative neuromonitoring was focused around metro cities, Bangalore, Delhi, Bombay, and then there was, in the south, it was better. It was, it had penetrated through the district level also. This was 3 years back, mind you. Today, if I have a data on this, I can bet to you the whole of India will be covered. Every district, every state will have neurosurgeons using intraoperative neuromonitoring, and they have understood that it makes the neurosurgery safer. So this is, I unfortunately don't have today's data, but this I wanted to show just to emphasize on how intraoperative neuromonitoring has gone through, and it has penetrated the whole of the country. So who should do IONM? That is another question which people generally ask. Neurophysiologists, there is no doubt, the neurophysiologists are the best people to do intraoperative neuromonitoring. Unfortunately, we don't have enough neurophysiologists in the clinical practice who want to help, at the patient side in all operation theaters to do intraoperative neuromonitoring. So Neurosurgeons, they want these neurosurgeons will want the intraoperative neuromonitoring, but for them to do a surgery and also look at the monitor will be very difficult. So they cannot, look at the signals, and it's a very difficult process for them. Technicians, yes, there are technicians whom we have trained and who are doing a good job across the country. Industrial support is also there, but I feel in neuroanesthesiologists can take a very good role in this field, because we are already monitoring the patient from the beginning, to the end of the surgery. We are there with the patient, so we understand the physics, we understand the physiology better. So I feel a lot of neuroanesthetists nowadays are interested in intraoperative neuromonitoring, and they're contributing to doing intraoperative neuromonitoring. In what cases we should do? In all cases, probably it's an overkill, because it will be an economical burden also. But some people say, how do you know whether it's an abnormal signal when you have not seen a normal signal? So start with the normal cases and then go on to the abnormal cases. Some people use it for very high risk neuro deficit cases, and this is probably how it's used in most of the places across India. In the West, there is another dangerous area where, for all cases, medical legal for the having medical legal protection, intraoperative neuromonitoring is used. So it's an area of the controversy how it has to be used. So now coming to the neuromonitoring techniques as such, there are two kinds of monitoring techniques. One is the sensory pathways. Like I said, these are ascending. So if you stimulate or if you pinch your hand at your wrist, so the signal goes on through your nerve, it goes on to your posterior column in your spinal cord, and then crosses across at the cervicomedullary junction, goes on into a sensory cortex. So you record your response in the sensory cortex. Likewise, your visual evoked potential, like I said, you give stimulation to the retina and record at the occipital cortex. Your auditory evoked responses, you give auditory clicks and record at your temporals. These are all the sensory pathways that can be monitored. The motor pathways are the descending ones. That is the opposite. So you stimulate the motor cortex and record the responses at your muscle level. So this is the normal, how the sensory evoked potential goes on, and it can be monitored. I'm not going to go into too much technical details. I don't think it can be covered in this talk. These are the various equipment that we use. These are the corkscrew electrodes. These are the needle electrodes that we use. These are the sticker electrodes that we use for stimulation as well. This is how they are placed on the scalp during the intraoperative period, the corkscrew electrode, so that the electrode also doesn't come off the scalp. And this is the motor evoked potential again. Here, like I said, it's the opposite. So you stimulate the motor cortex and then evoke a response at the muscle level, and you record at the muscle level. This is the needle electrodes, which is placed in the muscle, and then you record the response for your motor evoked potential. This is how a normal MEP, motor evoked potentials are the most common and most commonly done modality of intraoperative neuromonitoring, because what we are worried is the motor deficits. And this is the normal MEP waveform, how it looks like. This is a polyphasic waveform, and you can see the amplitude from the top to the bottom. This is the amplitude, and the latency is how late the response is coming. You can also do cranial nerve monitoring. You can do all your cranial nerve, facial nerve, lower cranial nerves. All the cranial nerves can also be monitored during intraoperative period. This is the brainstem auditory evoked response. This is how the auditory clicks are given through earplugs and then record the responses at your auditory cortex. So this is how a multimodality neuromonitoring is going on in this case. Probably this was a brainstem glioma which was being operated. So you can see the various waveforms, and continuously the monitoring is going on. So today's concept is of doing multimodality neuromonitoring. So it's not about one modality. You combine a lot of modalities together to look at how you can protect the neural tissues. This is also one such case which I wanted to show. This is a skull-based tumor. You can see the optic nerve here, and the surgeons were worried when they were going through the subfrontal approach. When they are QSIing the tumor, they can injure the optic nerve. So we were using intraoperative visual evoked potentials. These are the goggles which stimulate the retina, and the responses are recorded in the occipital cortex with these corkscrew electrodes. So this is the response that is continuously monitored, and we look at latency and amplitude. That is what we look at. So everything in intraoperative neuromonitoring is about latency, amplitude. This is EEG or electrocorticography. So this is a grid or electrode which is placed directly on the cortex, and you can use it for various uses. The most commonly used for electrocorticography is for epilepsy surgeries, where we look at seizure activity. We can see how after surgery the seizure activity has come down, and to identify the seizure focus also. Also, for orthopedic surgeons who are interested in spine, you can also identify whether a pedicle screw is properly placed inside the pedicle. If the pedicle screw has caused a medial cortical breach, like in this case, you get stimulation at very low currents. So here you don't want a response at a low current. So you stimulate the pedicle screw directly and look for how much current is required to revoke a triggered EMG. So this is how you can identify whether a pedicle screw is exactly placed in the pedicle and not causing a cortical breach. I'm just giving some examples so that the audience can understand how it is used. Another area is pediatric neurosurgery. This also in spinal dysraphisms, like in lipomyeningomyelocele, where a big neural placode has, there is a neural tissue lying in there, and you want to separate out the neural and the non-nervous tissues. You can use stimulation and you can use intraoperative neuromonitoring to keep the surgery safer. This is one such case where we were doing in a small kid, I think this was around a 4-5 month kid, where we're doing anal sphincter monitoring and continuously recording for anal sphincter, monitoring for the sacral EMG. This is a small video that I have just to understand how it is done in pediatric cases. So this is the phylum terminal, which is a non-nervous tissue. So when the surgeon is stimulating the phylum, there is no response. But now when he has moved to a nervous tissue, you can see that there is a response that is evoked. So you can simply identify which is a nervous tissue, which is a non-nervous tissue. This is the anal sphincter EMG, which is being recorded. Coming to non-neurosurgery, so there are various non-neurosurgical implications for neuromonitoring as well. Wherever you have neural structures around the operating field, you can do neuromonitoring. Most commonly, the thyroid surgeries, the recurrent laryngeal nerve is being used. Facial nerve monitoring for parotid surgeries, and also the brachial plexus injuries. There also intraoperative neuromonitoring is continuously being used. This is the endotracheal tube with a sensor, which is used for thyroid surgeries, where the surgeon can stimulate while he's doing the thyroid surgery, whether it's a nerve and whether how close he is from the recurrent laryngeal nerve, and he can record a response. Various factors that can affect intraoperative neuromonitoring, hypothermia, hypotension, these all have to be managed before a surgical warning has been given to the surgeon. So good checklist, good communication between the teamwork, and so it requires a lot of sync between the neuroanesthetist, neurosurgeon, neurophysiologist. Everyone has to work together as a team to do a good intraoperative neuromonitoring. I'll skip all this just to a few slides on image guidance. So image guidance has also made neurosurgeries a lot safer. This is a dye, fluorescein, which we give intravenously, and then you can see the tumor just glows up like a Christmas tree, and the surgeon uses a blue light and he can see the tumor glowing here, which can help him to remove the tumor. This neuronavigation technology, this is kind of a GPS technology inside the brain. So just like Google Map, how it will tell you where to go, which side to go. So neurosurgeon can use preoperative image guidance along with neuronavigation to understand where the lesions are. This is intraoperative MRI, which I was fortunate to work with for the last 5 years in Yashoda Hospitals, Hyderabad, where in between a neurosurgery, we take the patient to an MRI scan when the closure has not happened yet. We just pack the patient sterile, take the patient into the MRI scan, do an MRI, see if there is any residual tumor, and come back and then chase the tumor. And you can make sure that you have removed all of the tumor with this intraoperative MRI technology. A lot of challenges for anesthetists. I'm not going to go into details of all this. This is one such case where MEP or motor evoked potentials was performed on a pregnant patient. I'm just going to highlight how this case was done with team work and a lot of multimodality IONM. So this was a tumor in the intraventricular region going towards the internal capsule, and surgeons wanted motor evoked potential for this case. In a pregnant patient, we looked at literature. There were very few cases where MEP was performed on pregnant patients, because the MEP stimulation can cause an abortion, to the fetus, because it can contract the abdominal muscles also. So what we did in this case was we used intraoperative neuromonitoring technique with low current, with changes in the stimulation parameters. Then we also did uterine cortico, the uterine tone measurement. We did ultrasound measurement of fetal heart rate. We were continuously monitoring for the baby's well-being, and the obstetrician were also involved with uterine relaxants ready if in case an abortion or something like that sets in during the neurosurgery. So just to focus that it requires a lot of teamwork when you're doing intraoperative neuromonitoring. This was once other case which I wanted to show. This was visual evoked potentials being done in a deep brain stimulation. So deep brain stimulation is done for Parkinson's patient, and this is generally done awake. But in this case, this lady had a lot of dystonia, so she couldn't lie. On every 3 to 4 minutes, she would get a dystonic episode. So this patient could not be done under general anesthesia. So what we did was we used a VEP guided technique where we used VEP to guide us to place the deep brain stimulation electrode. And once the electrode was placed, we used image guidance also, that is intraoperative MRI, to show that the DBS electrode was placed correctly. So intraoperative neuromonitoring along with image guidance will probably give the best results to achieve the maximal safe resection that we want in today's era. So just to tell that the equipment is complicated. You can get bogged down when you look at intraoperative neuromonitoring. If you enter an OT where intraoperative neuromonitoring is going on, you'll see a lot of wires, but the concept is simple. So what I would say is, if you understand the concept, what is being monitored, what is anatomy, where the surgeon is performing a surgery, and what you need to monitor, the concepts are simple. So I think it's an initial step that is difficult. After that, neuromonitoring is not that difficult to understand. This is my team, which I have worked for the last 5 years. You can see this is Dr. Anand Balsubramaniam. He is himself a JIPMERite, and he was our chief neurosurgeon. And there are a lot of other JIPMERites. This is Savit. I don't know if you guys know him. So these are this was our team when we used to perform intraoperative neuromonitoring in Hyderabad. And it requires a lot of teamwork. So initially you do simple things, and then you can do complicated monitoring techniques. A lot of teamwork between the staff, anesthetists, neurosurgeons, technicians, a lot of teamwork happening. Thank you. And this is one of my YouTube, I just created a channel where you can access neuromonitoring videos and lectures to understand. So if any of you are interested, you can log on to this. This is my channel on YouTube. Thank you, madam.
Shyam, do you want to take questions now or after everything's over?
I think we should do some questions now. There's only one question in the chat. Well, I had a very practical question, which is, so when for neurosurgery, you're doing IONM, is there a separate anesthesiologist in charge of all the regular anesthesia stuff and a different person who's in charge of the neuromonitoring?
Yes. So in our institute, when we did intraoperative neuromonitoring.
Sorry to interrupt, Nitin. Can you just stop sharing your screen? So that
okay, ma'am. Yeah. Yes. So how we used to do intraoperative neuromonitoring in our center is, we had one dedicated anesthetist who would look at only the anesthesia, and he would do the anesthesia monitoring. And then there was a senior anesthetist who used to do neurophysiological monitoring, and he would interpret the signals. So initially, when we start the case, a technician helps us to put the electrodes. We have trained technicians, and the anesthetist who is inducing the case, who takes care of anesthesia. And then there is another neuroanesthetist who takes care of the monitoring and the interpretation. We never did any neuromonitoring case with less than 2 people. So it was always 2 anesthetists who was doing this. If we didn't have a neurophysiologist, if you have a neurophysiologist, we'd concentrate on our anesthesia part and let them do the work. But unfortunately, we don't have enough neurophysiologists in the country, and they're not into the clinical practice. So that's a difficult challenge that we face, that we used to face in India.
Okay. Yeah, I think in some place in the US, like in the Pittsburgh area, the whole neurophysiology monitoring is run by neurologists. And so they basically set everything up and they do it separately from the anesthesiologist, and they're in there, but they also collaborate. Okay. So there's one question which is in the chat, which is, how do you decide the site of electrodes for CP angle mass? This is from Herman.
Okay. So CP angle lesion, the whole neurosurgery is not about removing the tumor. The whole, the surgery is focused on preserving the facial nerve. That is the whole challenge, because a good, well-trained surgeon can remove the tumor well, but to preserve the facial nerve is the challenge. And when we do a CP angle tumor, we always monitor for facial nerve. We monitor for other cranial nerves around as well. Based on the lesion, we have a discussion with the neurosurgery team as to what they expect. We never decide the monitoring signals. It's a team that decides. The neurosurgeons tell us what all they would like, to have in place. So we would, for a CP angle lesion, I would definitely do cranial nerve monitoring, facial nerve monitoring. If it's a very big a CP angle lesion, I would also do brainstem auditory evoked responses to look at brainstem integrity. Also, motor evoked potentials to look at the long tracks which go through the brainstem. This is generally what is done for any CP angle lesion. It can vary based on the size of the tumor and where it's extending into.
Okay, thank you. That was a really good overview of the basics of IONM.
Thank you. Thank you, sir.
Okay, there's another question. What things in anesthesia should be avoided during IONM in thyroid surgery?
Okay. So any intraoperative neuromonitoring, the anesthetist role is very vital because the anesthetist has to understand what monitoring is going on. Unless he understands what monitoring is going on, he will not be able to deliver what is required. So in thyroid surgeries, if you're doing recurrent laryngeal nerve monitoring, this is what we call as triggered EMG. So what the surgeon uses is a stimulator, which he stimulates in the field and records for vocal cord movement, which is captured through a response through the endotracheal tube. So here in this case, it is better to avoid neuromuscular relaxants because this can hamper, your monitoring signals. And this is one thing. And then there are a lot of other things, challenges for the anesthetists. I think if we start going on that, it's a big topic, and there are a lot of senior anesthetists here who know that how it can get challenging during neuromonitoring because you cannot use the drugs that you can normally use. You are put in a difficult situation. You have to facilitate neuromonitoring, and anesthesia as such causes synaptic inhibition. So what in neuromonitoring you're looking for is synaptic transmission. So there's a direct conflict between anesthesia and neuromonitoring. So we have to create a fine balance where neuromonitoring can happen and anesthesia also is good so that the patient is comfortable.
Thank you. So I think with that, we'll go on to our next talk with you.
Kanchan, go ahead and unmute yourself and share your screen, please.
Yeah, share my screen, sure. Am I audible?
Yes.
Good evening, everyone. Thank you for this opportunity to present this topic in this forum. I never in my dreams thought that I would be sharing a screen with all the great people that are there on this forum today. So thank you so much. And for long, I have been, and I still am a fledgling neuroanesthesiologist, still budding. And for long, I have been that second neuroanesthetist who would look after the anesthesia part, and the senior neuroanesthetist would look after the monitoring. So now I'm beginning to do this, and I work with a very good neuro team at Vikram Hospital here in Bangalore, and I'm learning a lot from my senior, Dr. Tanmay, who's also from NIMHANS, whom I have joined here. So I will briefly take you through certain case scenarios which I have seen, and I have found IONM has been extremely useful in delivering a good neurological outcome to our patients. So anatomically, you could roughly divide the brain and spine surgeries that are in the purview of IONM into, say, supratentorial and neurovascular. In the supratentorial, you could have neurovascular procedures, you could have tumors in eloquent areas, you could have functional neurosurgery where IONM is useful, and of course epilepsy surgery. In the infratentorial region, again, you could have tumors, brainstem lesions, microvascular decompression, commonly done for trigeminal neuralgia. And coming to the spinal cord, again, of course, tumors, fractures, scoliosis, cervicovertebral junction anomalies, and dystrophism as described by Dr. Nitin. And of course, tumors in the peripheral nerves, and in brachial plexus injury, and thyroid and parotid surgery as discussed briefly. So I would like to go a little bit into detail with neurovascular procedures with a case that we did recently. So basically we use IONM to monitor the status of the neurological structures when we are having an ischemic state, which could be due to temporary clipping or cross clamping. So for example, in carotid endarterectomy surgeries, in aneurysm surgeries. And this will also be very useful in AV malformation surgeries, especially when eloquent regions are involved, when the deeper structures are involved in larger AV malformations. And there has been some application of IONM described in spinal vascular malformations as well. So I would like to take you through a carotid endarterectomy case that we did recently. So here we have a 70-year-old male who presented with history of left upper limb and lower limb transient weakness about 20 days before he presented to us. And he was evaluated by MRI that showed a small watershed infarct of the right ACA MCA territory. And he had around a 60% stenosis in the right proximal extracranial ICA, just near the bifurcation, as seen in MR angiography. He was a known diabetic and hypertensive with CKD, which is a common profile, and also had a history of peripheral vascular disease. And on examination, he already had a mild loss of dexterity in the left hand and foot. This patient was initially planned for stenting, but because of the tortuous nature of the blood vessels, stenting was deferred, and the patient was suggested for carotid endarterectomy because he was symptomatic, and even though he had only a 60 to 70% stenosis, benefit of doubt was offered in carotid endarterectomy, for which the patient consented. So here I would just like to, citing this article, I would just like to briefly mention that routine shunting or not shunting or doing a selective shunting is in the purview of the surgeon, and depending on their practice, different methodologies are used for carotid endarterectomy. So however, I would like you to look at the role of intraoperative neuromonitoring in deciding, in helping the surgeon decide whether a shunt is required or not, so that we get a comparable percentage of perioperative stroke risk, even in patients in whom originally a routine shunt may not be performed. So in my center, for example, a shunt is not a routine practice. And however, EEG, TCD, stump pressure, and SSEP are among some of the modalities that are used to identify at-risk patients. So in this 70-year-old male, we are mainly monitoring EEG and SSEP in our center for carotid endarterectomy. The main advantage of these two modalities being that they are continuous monitoring modalities. So there is no interruption. You can get a continuous signal even during the clamped period. So we have a 12-channel EEG, which is 6 channels on either side, along with somatosensory evoked potential. So the idea is to cover the entire territory of the brain that is supplied by the internal carotid artery on both sides, so that we also have comparison. So this is just an image to show the transcutaneous stimulation of the median nerve in the upper limb, and the posterior tibial nerve stimulation that is done behind the medial malleolus in the lower limb, and this is done bilaterally. So for this patient, after we induced general anesthesia, and the technique of anesthesia was a balanced anesthesia with muscle relaxant. So we secured baseline EEG and SSEP, and that is the first step. And following, so this is an image of the SSEP that was obtained. On the left side, we have the upper limb, and on the right side, we have the lower limb bilateral SSEPs. So the curve, which is in the graph, which is in red, is marked as the baseline, and the green ones are the ones which are stacked periodically as and when the SSEP is repeated, and that is a continuous monitoring. And the white one is the one which is being averaged. So what we did was, there is a routine practice of doing a test clamping, and which is done for roughly about 10 minutes. So we noticed a fall in spectral edge frequency, that is 95% of the EEG frequencies which are contained in this in the patient. So there is a fall in the SEF on the side of the clamping, that is the right side, so on the ipsilateral side during the test clamping, and that's when we identified that this patient is at risk. So EEG, basically there are many criteria. There are certain criteria which you can use to identify ischemia. For example, if there is increased slowing of the alpha beta frequencies, or there is increased appearance of delta, and appearance of theta waves when the depth of anesthesia was initially not that deep, with a sudden appearance of theta waves. So in this case, you can see the top is the left side and the bottom is the right side. And here on the ipsilateral side, we had noticed EEG changes, although there were no changes in the SSEP. So this is the timeline of various events that we can record in the monitor, in the IONM monitor during the surgery. So here I would just briefly so we decided that this patient requires neuroprotection. So neuroprotection can be given in terms of like shunting is not being done. So we need, from the anesthesia side, we need to provide neuroprotection. So we are going to give burst suppression and we are going to maintain a good, a higher than normal blood pressure, 20 to 25% higher than the mean arterial pressure is going to be maintained to ensure some amount of cerebral protection. So this is how we monitored the EEG and induced burst suppression. And at the same time, simultaneously, the SSEPs were going on. And even though we had burst suppression, we had almost 100% burst suppression in the EEG, the SSEPs continued to be intact. And so we reduced the cerebral metabolic rate of oxygen by increasing the sevoflurane and keeping 100% oxygen, as you can see in this brief video. And in this, we also used propofol, and atracurium and fentanyl infusion was used as a part of balanced anesthesia. And we also ran a background infusion of noradrenaline to make sure that the blood pressure is 20 to 25% higher than the mean arterial pressure. Yeah, I think a slide got missed. Okay. Yeah, so the surgery went on we had a clamp time of around 20 minutes, and then after that we were able to extubate the patient. However, post-operatively, the patient did have a slightly increased weakness of the left upper limb and lower limb. And an MRI was done, which showed a fresh watershed infarct in the MCA-PCA territory. So what I mean to say is that what the message that I want to convey is that if we had not identified that the EEG slowing was there in this patient during the test clamp period, and we had not initiated neuroprotective measures, it is possible that the deficit that this patient had would have been worse than what we had. The patient went home with a power of slightly more than 4/5, and it was gradually improving. So had it not been for the identification of the EEG changes, probably we would have had a worse outcome. This is IONM in functional neurosurgery as described by Dr. Nitin. And most of the time we do it under awake craniotomy. Dystonia cases, sir has described one case in which they gave general anesthesia. We have done one case in which we wanted to get good VEP signals and we used dexmedetomidine. So we gave a test infusion of dexmedetomidine the day prior to surgery and saw that the patient was able to lie down for a significant period of time with dexmedetomidine in the trial period in the ICU. So the next day the same technique was used, and luckily we were able to complete the surgery in dexmedetomidine and also get good VEP signals during the surgery. So the idea is that in dystonia, for example, the globus pallidus internus DBS is performed. And as you can see in this diagram here, it is very close to the optic tract. So that is the reason VEP needs to be monitored. It's also very close to the internal capsule. So if you're doing it under general anesthesia, it's worthwhile monitoring the evoked potentials as well. So this is how a general setup of an awake craniotomy will look. This is specifically for DBS. However, you'll have a similar setup for any awake craniotomy where you need to actively neurologically monitor the patient during the surgery. This is an MRI showing the same thing where the GPI nucleus is close to the optic tract. And this is how VEP would be done intraoperatively. And you would get a response like this, and you would like to look at the disturbance in the VEP responses during the surgery. So VEP can be used either as a guide to locate the GPI nucleus, or it can also be used for monitoring to make sure that the VEP signals are not lost. And coming to, again in the supratentorial region, coming to tumors in and around eloquent areas. For example, this can be done under awake craniotomy or under general anesthesia. So the type of monitoring that you will do will differ depending on the modality of anesthesia that you're using. So motor mapping, for example, if you're doing it under general anesthesia, the surgeon will be able to map out the motor area using cortical as well as subcortical stimulation. So, and subcortical stimulation now can be done in a continuous manner by using a suction stimulator probe, which the surgeon uses to gauge the distance from the motor tract. So if the surgeon, the normal formula which is used, which is found to be consistently good up to about 5 millimeters of distance from the motor tract, is a 1 milliampere current which is applied, is equal to a distance of around 1 millimeter from the motor tract. So if you're having a patient under awake surgery, you can do motor mapping by negative motor mapping, whereas when you stimulate, the patient loses the function of that particular functional area. So similarly, you also want to identify the central sulcus, because a tumor like this can also displace the motor cortex. So we'll have a look at that. And of course, a patient under awake craniotomy we will be able to map the speech area in a patient with awake craniotomy. And of course, SSCP and MEPs as mentioned. So this is a diagram showing subcortical continuous motor mapping, where the surgeon is dissecting and at the same time able to gauge the distance they are from the motor tract. So initially the cortical mapping will be able to map out only the first few millimeters from the cortical surface. However, the tumor will extend deeper, and anywhere along this tract, a damage to the motor tract can happen, and that can also lead to very dense motor deficits. So the idea behind any sort of motor mapping here is that it enables complete resection and near total resection, which will ultimately improve the survival and lead to better neurological and functional outcome. And these IONM is also aided heavily by a good preoperative functional evaluation of the patient by using functional MRI or DTI, diffuse tensor imaging, which will map out the eloquent area, so that you already assume you already have a reasonable anatomical idea as to where the functional areas are and how close the surgery is. So here is a video of speech arrest, speech mapping, which was done during an awake craniotomy. You can notice the slowing in the speech.
Sir, stop.
As the speech areas.
Yes, sir. Yes, sir.
Yes. So similarly, we also need to map out where the motor and the sensory areas are. So basically, we want to find out where the central sulcus is. So it could be an epileptic focus, an epilepsy lesion, which is which has led to displacement of the normally expected central sulcus or the motor area. So basically what we are doing is we are looking for a phase reversal of the SSCP signal. So basically we are stimulating in the peripheral nerve, and we are looking for the signal, and we want to localize where the somatosensory cortex is, where we are going to get a normal SSCP, like an N20 response. And once we cross over from the central sulcus onto the motor area, we are going to get a phase reversal. The signal is going to be reversed in the when we come across on the other side of the central sulcus. So this is how a phase reversal will look. There is a complete change in polarity of the signal. So the shifting of functional areas due to tumors or dysplasias can be identified using this technique quite reliably, and safe resection of the tumor or epileptogenic focus can be done. This is just a diagram depicting, already described by Dr. Nitin, how we are stimulating in a peripheral area, and anywhere along the path of the sensory pathway, we can identify where there can be a damage. So we can either find out what's happening at the ERPS point, what's happening at the cervical region, or what's happening at the cortical region. So this is for the upper limb, and similarly for the lower limb, where you can stimulate either at the posterior tibial nerve or at the common peroneal nerve at the neck of the fibula. So infratentorial surgery is as described by Dr. Nitin. So CP angle tumors, it is standard of care now to monitor the facial nerve at least, and depending on the size and extent of the tumor, the team can discuss as to what other cranial nerves they would like to monitor. And if there is any hearing that can be preserved, you can do a brainstem auditory evoked response as well. And since this surgery involves positioning the patient in the lateral decubitus position, SSEP monitoring with ERPS point is worthwhile. And also EEG monitoring in any form, either raw EEG or processed EEG is recommended, because we are going to change the anesthetic technique in these patients, where you're going to depend either on completely on TIVA, not use muscle relaxants, etc. So this is an example of how a patient would be positioned. I've taken this particular case scenario from the Society of Neuroanesthesia website, SNAC website. So here they've described a patient who had an uneventful awake fiber optic intubation, and they obtained baseline SSEPs from the right and the left and the right upper extremities, and intraoperatively, accidentally, the patient's head slipped, and that led to the displacement of the cervical spine neutrality, and they promptly replaced it. However, after 15 minutes, they noticed that there was a loss of signal here. There was an abnormality in the SSEP signals on the right upper extremity, and the patient was in the right lateral decubitus position. So the right side was dependent. So the quiz on the website asked us, like, what could be the cause of the SSEP signal change? Is it due to systemic hypotension? In that case, all the SSEP signals should have been lost, but only the right upper limb extremities SSEP signal was lost. So that's not the case. Could there be a technical problem with signal acquisition? Well, all the other SSEPs were okay. Could there be a change in end-tidal sevoflurane from 0.5 to 0.8 Mac? If this happened during the surgery, would that have resulted in that? Again, all the other SSEPs were acquired. So could it be a surgical neurosurgical trespass? Like, was there a damage from the surgeon's side? Likely not. The surgeon said there was nothing wrong. So finally zeroed in on a positioning problem. So it could be a vascular compression, it could be direct compression of the brachial plexus or a stretch. But they were quite astute to identify that erroneously a blood pressure cuff had been left in a continuous inflation mode, and which is why the SSEP signal had been lost. So otherwise there was no other real problem. So even small problems like this can be identified and solved using SSEP signal change. However, we need to look at the patient as a whole during this. This is just an example of a CP angle tumor. Coming to EMGs. So during CP angle surgery, this is how the facial nerve monitoring is done. So here the facial nerve is stimulated at the surgical site, and we are getting the corresponding EMGs, triggered EMGs in the muscles. Videos going. So in this case, the surgery was coming to an end, and then we started seeing these small bursts of discharges in the facial nerve, the orbicularis oris, and this unfortunately continued till the end of the surgery, and the patient also had a deficit post-operatively. So this is how an abnormal raw EMG might look like. IONM also has a role in microvascular decompression. Identification of the 5th and 7th nerve using EMG would also be good, like in case sometimes just to identify the nerves and be sure that we are decompressing the right nerve. And also SSEP with ERPS point is a useful modality to identify any position related problems. Coming to a brainstem lesion, so this was a 65-year-old lady with a brainstem cavernoma at the level of the midbrain, and this is how her MRI looked. So for her, we monitored SSEP for the sensory tract, motor tract, MEP, and EEG, of course. And we use triggered EMGs for 5, 7, 8, 9, 10, and 11, all the lower cranial nerves as well as 5 and 7, along with brainstem auditory evoked response. And we did not do 3, 4, and 6, but next time around I will monitor these as well. So this is how we could arrange our screen, and we see all the modalities that we want to monitor at one shot. So brainstem auditory evoked response, these are the baseline readings that we have got. This is the SSEP. This is the motor evoked potential response of both the upper limb and the lower limb. This is the SSEP of the lower limb. So this is baseline, and at the end of the surgery, unfortunately, we did not get good MEP traces. The SSEP traces were reasonably okay around the baseline. And this patient unfortunately woke up comatose, could be due to various reasons because of surgery at such a crucial part of the brainstem. And however, we had intact SSEP, we had intact brainstem auditory evoked response. So we were hoping that over time she will make recovery. And the patient's son shared this video with us, where she did make some amount of recovery over the period of 2 to 3 months in the rehabilitation center. So we have poor prognosis is to be expected in such a location of tumors, but we can at least monitor to some extent and try to improve the neurofunctional outcome that we can give the patient. Similarly, SSEP and MEP can be used for monitoring of the spinal cord during excision of lesions such as this, like the meningioma. And what is also very useful in modalities like these is what you can monitor continuously. And these are nothing but the D waves. So D waves are something where the stimulus is given proximal to the lesion, and you monitor the responses distally. And this can be done continuously while the surgery is going on. So this is an example of a D wave. So the difference between D wave and MEP, the advantage of having a D wave also along with the MEP is that even if in a situation where the MEPs are lost, MEPs are like polysynaptic, the result of multiple synapses at the end of which you measure the muscle activity. However, the presence of a D wave, even at the end of the surgery, even if the MEPs are absent, will indicate a reversible neurological deficit if at all a patient has that. However, if we lose the D wave also during the surgery, it is quite likely that the patient will have an irreversible neurological deficit. Similarly, in this case, like a compressed spine fracture, we monitor both the SSEP, MEP, as well as EMG triggered and free run. So this is the evoked potentials that we got, sensory and motor evoked potentials for this patient, and the patient had good functional recovery after surgery. Similarly, this is a badly herniated intervertebral disc, again at the end of which we had good motor evoked potentials and the patient had good functional recovery. Cervicomedullary junction cases provide unique challenges, as we all know. And in this case, this is a 56-year-old patient who already was operated. Posterior fixation was done for him at the age of 15 years, and 45 years later, he had come with myelopathic symptoms. So the critical steps in this patient obviously were intubation and positioning. He was intubated in an awake state, and positioning was also done carefully. And throughout, SSEP, MEP, and lower cranial nerves are monitored in this patient along with EEG, and he had reasonably good functional outcome. Similarly, IONM is useful in peripheral nerve lesions, nerve sheath tumors, lipomas, carotid surgery, and thyroid surgery. So this is Nitin sir's paper where there was a tumor, there was a schwannoma of the sciatic nerve. It was extending into the sciatic notch. So it was not possible to monitor the sciatic nerve in the entire extent of the schwannoma. So because anatomically it is difficult to go through the sciatic notch and monitor the site of the sciatic nerve proximal. So therefore, if you do a transcranial MEP and SSEP as they did, you're monitoring the entire tract from the cortex till the periphery, and also similarly stimulating at the periphery and detecting the signal at the cortex, and therefore establishing the continuity. And they had a very good outcome in this patient. They did see a 10% decrease in SSEP, but no change in MEP. So the patient had a good motor outcome. So basically, this is what we want for all our patients, even though they come seeking help, they have disabilities when they come. So we should try to give them the best outcome possible. Thank you all.
Thank you. I think that was a really good bunch of examples that you gave. So I'll just post one question. So both of you focused on mainly neurosurgery, which kind of makes sense. That's where we want to really monitor the nervous function. What's the process for things like cardiovascular surgery, like open heart surgery? Are you involved in ischemia monitoring of the brain?
Sir, in my center, as of now, we are not, but we are occasionally called to do transcranial Doppler to look for, so we see something called microembolic signals whenever there are embolic showers. Yeah, so when the surgeons are quite concerned about the neurological outcome. And I've also seen cardiovascular surgeons use, cardiovascular anesthetists use NIRS, that is a near-infrared spectroscopy, to look for the cerebral oximetry, any changes in the cerebral oxygenation across the hemispheres on each side. So these are the couple of things that I have seen, but actively I have not been involved. Maybe Nitin sir can throw some light.
Yeah. The challenge, unfortunately, is that in cardiac cases, they use extreme hypothermia, and the hypothermia will prolong the the signal latencies, and it's very difficult to get good signals. I have tried it in a few abdominal aortic aneurysms where hypothermia was given. I had to basically look beyond my screen, so I had to change my time frame and then look for long latency signals. But definitely intraoperative neuromonitoring can be used. There is no doubt about it. And there's a lot of concern about brain when cardiac patients go on cardiac surgeries, patients go on bypass. And intraoperative neuromonitoring can play a role, though it can be a little challenging. The cardiac anesthetists themselves use, like Dr. Kanchan said, the other modalities. For neurophysiological monitoring, because hypothermia as such poses a big challenge, it's not very popular in cardiac surgeries.
Okay.
Dr. Hemant Vaikar has asked the question, probably you have answered it. What monitoring device will you suggest for arch aneurysm surgery under total circulatory arrest?
Yeah, the same, madam. Basically, here, if you're doing an arch aneurysm, I suppose the risk is for developing a paraplegia, and you need to monitor for lower limb motor evoked potentials. You can monitor for lower limb somatosensory evoked potentials, and also you can monitor the brain as well by doing EEG and as well looking at NIRS. So these are the modalities that can be used in arch aneurysms.
Dr. Prasanna, we'd like to hear from you about both the talks as well as any additions you would like to make.
Yeah, madam. Thank you. Thank you for inviting me. And both Nitin and Kanchan are very close to me, and it is nice to hear. I might have heard this topic from Nitin 20-25 times. And every time I don't miss it. I enjoy listening to him. And as far as Kanchan is concerned, I'm over the moon. She's my student. She has been my student. I was even the thesis guide. So I think she's doing much more better work than what I do here. Having said that, we have so we have all the monitors now in Jipma to do almost every case. We have the EMG monitoring. Every possible man. Fortunately, we have a PhD student in neurosciences who is doing the study. So we are basically looking at.
Sorry to interrupt, Dr. Prasanna. We can't hear you properly. Maybe you can shut your video. We might get a better bandwidth. Your voice is breaking.
Yeah. Is it okay now?
Better.
Yeah. So we have a neurophysiology PhD student now who is doing the PhD study in neurosciences on IONM. Basically, we are looking at olfactory pathways, stimulating them, and whether we'll be able to get the olfactory signals. We are trying to get those new electrodes formed by neurosurgeon and guide for that research. We are looking into that. So, this concerned IONM, she is managing well. So, we have been pretty happy with her. And I think she's trained by Nitin only. And Nitin has guided her through whenever she finds some problem. So it is wonderful to listen to you, Nitin. And thank you very much. And congratulations to both of you for a wonderful talk.
Thank you, sir. Thank you so much.
Thank you.
You are yourself involved in, neuromonitoring. So would you like to add something?
Yeah, I will just add that I don't actually actively do neuromonitoring, but I'm kind of involved in looking at the bigger picture here. So one of the studies which came out from Pittsburgh showed that surgery in the elderly, there's often cognitive problems in up to half of them 1 year down the line, when you look at them up to a year down the line. And some of the reasons might be due to anesthesia, due to the surgery, but also now there is thinking that blood flow to the brain, even small changes in the elderly, is probably not tolerated very well. And so the surgeons are coming and making a case that they want basically at least EEG monitoring intraoperatively for many of the elderly. The cardiovascular surgeons now use continuous EEG monitoring pretty much for all open heart surgeries. And they've reduced some of the complication rates. And in fact, now there's a protocol, they're trying to set up a protocol in the hospital, which is a stroke protocol, which can be called intraoperatively if we suspect that there's a stroke. This is typically with cardiovascular surgery and sometimes with CEAs. And so the idea there is that the stroke neurologist can come in, the interventional stroke neurologist, get an image done and do embolectomy if possible. And they've done 2 cases so far where the operation was stopped, embolectomy was done, and there was very good recovery in these patients when they took the embolus out. So I think it's going to become more and more widespread, the brain monitoring, and a case is being made now that if we are going to be monitoring the heart continuously under anesthesia, the brain should be monitored too, because the brain is, if anything, more important than the heart at the end of the day. And so, so the challenge, of course, is like, we don't have standards yet. A lot of this is based on experience of the monitoring folks in terms of how they decide what is what is not. So there's some work going on here where, because this place has got 40 hospitals spread across the state, and they don't have neuromonitoring people at all the ORs, and the demand is increasing. So they're starting to now have just technologists who set it up and they pipe the EEG signals to a central place. And in fact, one of the main neurophysiologists who does monitoring, he's often monitoring like 6 to 7 simultaneously. This is just for looking for ischemia in the brain, not for neurosurgical procedures. And so one of the projects that we are working on is to try to at least have some kind of AI-based, artificial intelligence-based signal, which would pick up just to say that, okay, this looks like ischemia. Because when you're monitoring 6, 7 surgeries together, or help the technologist who is in the OR to give them a signal saying that this looks concerning, and then have the physician look at it immediately and make a decision. So that's one piece. The second area, which is also very interesting, is out of the hospital monitoring of neurofunction is starting to get some traction. This is typically for when the paramedics in an ambulance go out to pick up someone who is not responsive. You need to figure out whether a stroke has happened. That's one of the things, because if a stroke has happened, then you could potentially treat them in the field. And so they're starting to use like 2-lead EEGs, monitor them for about a few minutes and try to figure out whether there's a large vessel stroke, in which case they would prioritize the the imaging quickly so that they can be treated. So it's kind of going to spread out from the OR all the way to the outside of the hospital. It's also starting to spread out into the ICUs, where there are people who, after 24 hours, a stroke is discovered for various reasons. It's not picked up immediately because the patients are sleepy or they're under medications. And so having monitoring would help there too. So there's a lot of effort now about monitoring just high-level brain function using simple things like EEG across many care settings. So that's where things are headed at this point.
So Anand has joined us, and Nitin has worked extensively with Anand. So Anand, we'd like your surgical perspective of today's proceeding.
Thank you, Vidya. As a neurosurgeon, we have gone through, from my training in mid-90s, I have seen that monitoring nerve function, which we are trying to preserve while operating, has been foremost for all neurosurgeons. But unfortunately, as Nitin mentioned, we have not had a drive of neurophysiology to help us in the theater. Even though in a place like NIMHANS, we had so many departments, we can even do awake craniotomy with a neurophysiologist coming over and monitoring. But to have a trained neuroanesthetist with monitoring was always difficult. But I should say now with DM neuroanesthesia programs, and before that, the post-diploma certification course in neuroanesthesia had started. So the personnel attending to neuroanesthesia has increased. And I feel that is the main reason why neuromonitoring is picking up in a big way. Because neuromonitoring is not a new technology. It is there way back. You know, people have been doing this for a long, long time. But we didn't ever have personnel in theater to do it for us. So we had to double up as neurophysiologists ourselves, and we used to monitor. One of the residents used to stand on the other side and monitor awake craniotomy. Then an interested anesthetist like Dr. Umameshwar Rao in NIMHANS, he used to help us monitor patients. And then slowly when the hands started improving, like with having more training of PDCC residents, then a dedicated DM neuroanesthesia program. And thankfully Nitin joined us at Yashoda and we could drive the program at Yashoda. The questions are always there for the neurosurgeon to ask, am I doing the right thing? Am I putting the organ at risk? Is the nerve at risk? The questions have always been there. To get the answers, the equipments have been difficult to come by. Thankfully, now the companies are circulating the neuromonitoring equipment on a higher basis. That's a big thing. Otherwise, it costs a lot of money for a hospital to invest when you are doing maybe 10 out of 100 cases in a month with neuromonitoring. But with more and more people now available, so I think it has picked up in a big way, and it's definitely adding to the safety of surgeries. It reduces stress level to the surgeons like anything. I mean, Nitin can vouch for that. I'm sure Kanchan also can vouch for that. Not only the surgeons, even the anesthetists, the first people surgeons take out their irk is on the anesthetist. If something goes wrong, we always are ready to blame. You didn't give anesthesia properly, or you didn't watch for the blood pressure. That's why things went wrong. You know, who takes the blame when things go wrong in the post-operative period? But if you're monitoring and if you're sure that nothing has gone wrong during surgery, even if patient wakes up with a transient deficit, we can know that it is transient and it is going to improve over a period of time. And we can counsel the relatives confidently, saying that, look, what has happened is because, and mind you, our resections have gone to much more closer proximity to the nervous tissue. Previously, the standard excuse for neurosurgeons used to be, we had to leave behind tumor because, you know, there was a risk of the nervous tissue getting damaged. And nobody could argue that. And a post-op scan will show a large tumor still left behind. But now we are not in that era. We are now pushing the margins thanks to neuromonitoring being available, so we can literally do it. We can still land up with a deficit and still confidently tell the patient this is transient, it will recover, because during monitoring, nothing fell during the whole course. So it's a total paradigm shift of just doing safe surgery or hiding behind a safe surgery versus really making the surgery efficient and safer. I think that way, I think more and more neuroanesthetists should get interested and train. And as Shyam said, it's coming up in a big way in cardiac. People are monitoring heart for everything, but why not the brain? Because finally, there was a discussion about in cardiac anesthesia. I have seen cases with associated carotid stenosis, waking up with strokes. Like he beautifully said, 2 cases were prevented from having morbidity. I mean, that's wonderful. I think this is where probably it should go, to make sure that whatever surgery with the end organ of brain at risk or nervous tissue at risk, we should be able to avoid it by suitably monitoring it. And I'm really, really happy to see the neuroanesthetists, the anesthetists taking more interest, putting their hands up and coming forward and helping the surgeons out in this endeavor. Thanks for choosing this topic and the speakers. Both of them spoke wonderfully, and thanks, Shyam.
Yeah.
Radha has also joined us from US. She also does neuro anesthesia and neuro monitoring. Radha, would you like to say something?
Hi. Can you hear me? Yeah.
Yes.
Excellent talks. I work at MD Anderson Cancer Center. So we mainly do brain and spine tumors, and of course thyroid tumors as well. So we do use intraoperative neuro monitoring for brain tumors and for spine tumors, especially during awake craniotomies when we do surgeries on patients with brain tumors in the speech and motor areas. We definitely wake them up, and the new intraoperative neuromonitoring is also used in conjunction with the wake up and the testing. And we mostly use total intravenous anesthesia and try to avoid, and absolutely avoid muscle relaxant. And sometimes if they use only SSCP and no motor mapping at all, then we use a touch of sevoflurane or desflurane. Otherwise, we try to avoid inhalational agent as well. And for the most part, we have neurophysiologists, a team of neurophysiologists who come with their technologists who do the monitoring. So we focus on the anesthesia portion, and but we work with them, we work together with them, and we cater our anesthetic to the monitoring that they do, so that the patient is benefited by that. We work together really, really well. So depending on their monitoring, we do whatever is needed to be done so that their amplitude and latency are not affected at all. So that's my 2 cents worth. And I'm really impressed that you guys do awake craniotomies in India as well. And when I did my residency, MD anesthesia residency from JIPMER, we were sent to NIMHANS for a month and worked with Uma Maheshwar Rao at the time. And he was one of my teachers. And I fondly remember those days. Thank you, Vidya.
So Nalla, you wanted to raise a question?
Hi, Shyam, and it was a lovely talk to all the speakers. I just wanted to talk something about pediatric neurosurgery. And this is something that happened a few weeks back in Dubai. So this was a patient with craniosynostosis, a 3-month-old child weighing 6 kg, was posted for cranial remodeling and ZZ-plasty. The patient was anesthetized by a DM neuroanesthetist qualified from India, working in Dubai. The patient was in prone. The anesthetist was concentrated with the patient and he was doing his work. Whatever, the surgery took 3 hours. The anesthetist had 2 venous lines in place, 2 venous cannulas. The baby was just 6 kg. So he had enough blood in the theater. So one of the IV line was connected with blood transfusion, kept ready. The surgery started. The surgery finished after 2.5 hours. The monitoring was with blood pressure, cuff BP. He did not have an intra-arterial monitoring. ETCO2, pulse oximeter, other monitoring was there. At the end of the surgery, the patient was turned back to prone and he found the pupils dilated. Now the point is, the anesthetist was quite involved with the patient in the prone position, 6 kg, imagine, with a tube and trying to do whatever he can. The surgeon has been infiltrating the scalp with xylocaine and adrenaline. Now I just want to know from the panel, this guy just kept infiltrating wherever he was going to cut the scalp, so that one of the technicians just said there was no bleeding at all from the scalp. So he completely removed the scalp and then went on with the cranial remodeling and cutting the the suture thing. End of the day, when the patient was turned upside down, it was a dilated pupil. The surgeon blamed the anesthetist. Now, immediately after that, they noticed the patient was going into a circulatory shock. The blood loss was only 50 ml. The patient was resuscitated. The baby was resuscitated, taken straight away for a CT scan. CT scan showed no gross abnormality of any intracranial problems. The baby was shifted to the ICU. Resuscitation was continued. Blood was replaced. End of the day, the baby passed away after 10 hours. Now, my only simple thing was, and the surgeon just put the blame on the anesthetist. So much of monitoring is going on. In pediatric neurosurgery, how do we come out of such a problem? In fact, the urine output was adequate. Whatever, there was some mild hypothermia that also the anesthetist shared with me. I was not the anesthetist, but it's a very close friend of mine. My thing is that in your experience, when the surgeons go on infiltrating the scalp with xylocaine with adrenaline, just because they don't want bleeding, and these guys don't realize the dose of it. And it came to the knowledge that later on, that he had asked the nurse to give 30 ml of 2% adrenaline, 2% lignocaine with adrenaline in a bowl, which was not even disclosed to anybody. And he says that he just discarded some, I diluted a little bit and I've been infiltrating on the scalp. So I just wanted to know, what do you think, what sort of a monitoring would have helped? The anesthetist told me the heart rate was fine, ETCO2 was going on, pulse oximeter was good, endotracheal tube in place. He did not have an intra-arterial line. It was just a 6 kg child. He did not put one because he thought he'll put a femoral, but he could not because it is a prone position. But he had 2 venous access. End of the day, the baby died. And was it necessary to do a craniosynostosis surgery in a 3-month child? What's your opinion of this neuroanesthetist and Shyam? And nice to have you on the board, and anybody who can share on this, because this was something very disturbing in my mind. So I just wanted to know the toxicities, and when we infiltrate adrenaline, we do not realize that, what is the dose that goes on. The surgeons don't tell you. Could that be the cause?
So Dr. Prasanna,
what monitoring?
Dr. Prasanna, would you like to take that question, or Nitin, are you happy to take it?
Madam, I think the only monitoring that would have helped here is monitoring the surgeon. the anesthetist should have keenly monitored the surgeon, how much adrenaline he has taken, because in pediatric neuromonitoring it's a really challenging area, because we haven't been able to develop good monitors for pediatric neurosurgery, because the myelination is not complete. Lot of challenges with pediatric neuromonitoring, so we still don't have good neuromonitoring techniques for pediatric neurosurgery. And this, I think, was a simple. I mean, you already know the answer why the patient had a bad outcome. So, I mean, a lot of adrenaline infiltration probably has gone into
But it
systemic.
didn't happen immediately. It's after 2-3 years that they realized.
Yeah, but you didn't see the pupils, and how you are not monitoring the brain. So, you know, you're blind. You're just looking at circulation parameter. That's what Dr. Sham was focusing on. We don't pay enough attention to the brain still. So, I mean, this has this. I mean, we speak a lot about heart attacks, MI, but what about stroke? We still haven't progressed at all at stroke. So, I think Dr. Sham has already spoken a lot about that. So,
I would just like to say that whether it is adult or pediatric or any case, I just take the initiative, because I'm old school. I'm not a DM neuro, but for whatever you can say that we are grandfathered into these things from because of doing neuro anesthesia for many years. So, so the simple thing is, irrespective of the whether it's pediatric or adult, I calculate the dose and I make sure that the nurse draws only that much, and everything else is discarded. Just do not let it be on the table at all. I think that's the only thing we can do. And the other thing is, probably we take the initiative and give the scalp blocks ourselves in advance, so that okay, this much has been used. That's it. We have for this baby for the next 2 hours we cannot use anything more. Period. And then take it away. So Dr. Hemant asked a little bit to talk a little bit more about awake craniotomy. So Kanchan, would you like to take that?
Yes, ma'am. Sure.
Because I think in the US there's a lot of sleep awake asleep, but we tend to do more of pure awake craniotomies. I don't know about, I mean, I have worked with a surgeon whom you may have also worked. Dr. Ravi Mohan was in Vikram Hospital before, so I have done some epilepsy surgeries and all with him. But mostly we do fully awake. So
Right.
Can you just elaborate maybe 2-3 minutes on that?
Sure, ma'am. Now, I just saw Dr. Radha's comment that they place an LMA in the beginning and take it out during the awake portion. So the thing is, it is possible in some cases, I guess, but it depends on the indication for the awake craniotomy and the type of frame that the patient has fixed on his head. So it's not going to be very easy to manipulate the airway. Say, for example, if you have a Lexel frame in place when you're doing a DBS case. So what the commonly performed technique is that of an asleep, awake, and asleep. And even for putting the patient asleep, it is usually dexmedetomidine, which has been a game changer in the last 10 years or so, that we've been trained to use it in. And it's been really good, and supplemented with opioids, of course. And there have been reports where we lose microelectrode MER signals with boluses of propofol and things like that. So the idea is to maintain a stable state of anesthesia even during the asleep state. When we are planning to awaken the patient also, it should be a smooth awakening, and we should be able to put the patient back to sleep, back into the comfort zone of not just the patient but our comfort zone as well, so that we have good control over the airway. We shouldn't lose it. So that is a normal technique of awake craniotomy that we use. And sometimes in epilepsy surgery, for example, our children tend to be a little on the younger side, maybe like slightly older teens, in whom we might do an awake technique. So that becomes a little challenging. But then again, so far, the cases that I have done with the surgeons in NIMHANS as well as here, we've been able to manage with asleep, awake, asleep technique, even in teenage adolescents, where we have done epilepsy surgery in an awake state. So, but I don't have much experience in manipulating the airway in awake craniotomies, fortunately or unfortunately. But yeah.
Can I pitch in for a second, Vidya?
Sure, ma'am.
All right. it's nice that you guys do that. We only do brain tumors because I'm in a cancer hospital. So I do awake craniotomies only for mainly speech, and then sometimes motor if the surgeon feels like it's really important to do motor as well. So sometimes we do right-sided or left-sided awake craniotomies for motor, but mostly we do left-sided awake craniotomies for speech, tumors in the speech areas. And 99% of the time we do the asleep awake asleep technique. So either we have them supine with a bump so that they're kind of sloppy lateral depending on where the tumor is, or full lateral if the tumor is completely in the in the speech area in the temporal lobe. So for us, handling the airway is relatively easy. We actually put them to sleep in the position that they're going to wake up, in the full lateral position, and then place the LMA from the front, from the side. Try that. It's actually much easier than placing the LMA from the head end, like when you stand above the head. It's much easier to place it from the lateral aspect because you just have to push against the palate. And we have used the Supreme LMAs all the time. So with the Supreme LMA, I use what is known as a guided technique. So we put the OG tube through and let it stick out 4 to 6 inches outside the LMA, and then use that to guide your LMA down so that the tip of the LMA doesn't flip. And then it really sits really well. And if the OG tube, you're able to push the OG tube in really easily, then you know that your LMA is in very, very good position. And the advantage of the Supreme LMA is that it has an inbuilt bite block. So it's just easier to tape it, and the patient doesn't bite the LMA. And also the Supreme LMA is the only one that is compatible in the brain suite where we use intraoperative MRI. The intraoperative MRI suite, because the ProSeal LMA has a reinforced tube, so it's not compatible in the MRI suite. So that's why we have switched to the Supreme LMA, which is a disposable LMA for all the cases. And the other thing is we, once the OG tube goes in all the way, even if the head is turned this way or that way, when they place the Mayfield's pins. We only use one type of pin system, which is called the Mayfield pin system. It's a 3-pin system. So they adjust that placement of the 3 pins depending on the site of the tumor, whether in the brain suite or outside the brain suite. And we rely on effective scalp blocks. We have a cocktail that we use. We use 0.5% ropivacaine with 1 in 200,000 epinephrine added to it. And we use about 2.5 milligram per kilo for the patient. And then we use what is known as a selective nerve block for the scalp block. So we block 6 nerves on each side. The greater occipital, the lesser occipital, the the zygomaticotemporal, the auriculotemporal, and then the supraorbital and supratrochlear nerves on each side. So 6 nerves on each side. So it takes about 5 to 7 minutes to perform. And we've been doing this for over 16 years now since I moved to MD Anderson. So it's not difficult to learn. And when we did our global conference, we had a neuro monitoring workshop. We had a neuro anesthesia workshop where we demonstrated the scalp blocks, and then we had neuromonitoring people come and talk to us about neurophysiology. And it was a very interesting thing and only neurophysiologists take care of our neuromonitoring. So I'm aware of all the techniques that we use and we work with them. But for me, those waveforms are still squiggles on a sheet of paper. Sorry about that. I'm still not very comfortable doing the monitoring myself. I just work with them and focus on the patient and the anesthesia portion of it. Otherwise, we mostly use for infusions, we use propofol and remifentanil after the scalp block, and avoid long-acting narcotics and wake them up. And if the patient's extremely anxious, then we add dexmedetomidine infusion, a very, very small dose, so they're not too sleepy. I think I've said my bit. Thank you so much for the opportunity.
Dr. Vinny, would you like to add anything? Dr. Vinny Kapoor? If anyone has any questions that have not been addressed, please unmute yourself and speak in case we've lost track of the chat box.
Yeah. So I would just like to make a comment, Nalla, about your case, which is kind of becoming more and more common now, at least here in Pittsburgh, is all these complex surgical procedures, the entire team has to work as a team, right from the surgeon to the technologist to the anesthesiologist. So one example here, what has happened is the person who runs the neuromonitoring team is from the neurological side, so trained as a neurologist, but went into actually the neurosurgery department. So he's a full-time faculty member of the neurosurgical department. And about 5 years ago, so the neurosurgery department reports out their outcomes about every couple of months. And the reporting was done by the neurosurgeons. So the neurophysiologist went in and said, you guys are underreporting. If I were able to monitor a lot more, there are probably a lot more things that are getting done. Plus, you need to follow up and do some things. So two neurosurgeons agreed to have all their procedures monitored. And when they compared their notes, the neurosurgeons felt that their complication rate was 5% or something, while from the neuromonitoring perspective, it was around 15%. And then you could go and actually do more careful neuro exam, sometimes imaging, to show that there were deficits down the line. And the neurosurgical chair, when he heard about this, he basically declared that everything has to be monitored from then on. And over 3 years, they brought it down from what was around 15% to now barely 2% because of the monitoring, and also because they sit together. They also look at these complications and try to figure out what happened, and so on and so forth. And the Department of Anesthesia is also bought into this. They changed their name to perioperative medicine. The idea is that monitoring starts to happen before the patient is wheeled into the OR. And the anesthesiologist needs to know a lot of information about the patient so that they can interpret what they see in the OR, as well as understand what might be the risks. Because if you know what the risks are upfront, more precisely, then you can interpret some of this data far more quickly. And so, so now what they have is basically anesthesia, the neuromonitoring section, as well as at least in the neurosurgery department, they're all working together. And I think now it's going to start with the cardiovascular department. The cardiosurgery department also is starting to think about doing this. They think it's going to be important. So, so it's basically, the problem is, yeah, if you're going to have a team where the surgeon doesn't give you all the information, or the anesthesiologist doesn't have all the information, or the monitoring person doesn't have, then it becomes problematic.
All surgery is teamwork, but I think neurosurgery with intraoperative neuromonitoring, you have to really raise the bar. I mean, the teamwork just by namesake is not enough. Really, everyone should know what the other person is doing every minute of the time. So, building teams and maintaining teams is, a big challenge, and also letting younger people come in and train. That also takes a lot of effort from, there is a comfort zone among team members. Oh, we are working with each other for so long, so so they have to come out of their comfort zone to be able to get other people on board and train them, so that then they can go ahead and work independently elsewhere. So if anyone has anything particular to say, please unmute yourself. Otherwise, I think we've had a pretty good long session, and closing comments from Shyam, we'll call it a day.
Vidya, I completely agree with you about the teamwork. We work as a team with the neurosurgeon and the patient and also the neurophysiologist. I actually go and see the patient the previous day and give them a spiel on how the awake-cranie is done and what the patient should expect from us and how we're going to work as a team together and take good care of him or her. So they get reassured by that. And then we work with us. So we talk to the neurosurgeon beforehand. We've all been working together for years now. So we all know each other really well. And then we also know it's also key is how the neurosurgeon positions the head in the pin system after the patient goes to sleep. That will help us remove the LMA and replace the LMA as needed. So they work with us understanding that airway is key. I tell them if no airway, no surgery. If I can't take that LMA out, then I'm not waking the patient up. So we work together really, really well as a team. And then the neurophysiologist also comes and tells us if there is any change and asks us if we have done anything in the anesthesia. So as you said, teamwork is really, really key.
So, Shyam, your closing comments, please.
Yeah, so this was a great session, and listening to the two talks was really excellent. And hopefully in a future session, we'll talk a little bit about artificial intelligence, which is starting to make its way through both in anesthesia and in neuromonitoring and in medicine in general. And it's going to creep in. And it's going to be interesting because especially for complex procedures like procedures in the OR, the people doing the procedures, which are typically physicians, you need to have some understanding of how the AI is working. Just like the neurophysiologist needs to understand quite a bit about neurophysiology to interpret everything. The same thing is going to happen with this black box AI systems. And unless the physicians are kind of part of this whole intake of these AI systems, there is going to be almost no pushback at this point. At this point, we are seeing AI systems which are not even evaluated in controlled trials, but are being deployed at this point. So there are at least a couple of systems now which is being reimbursed in the US, which are going to, I think they're already deployed in the past 2 months, which basically do screening for stroke from imaging and autonomously send out emails to various people saying that the stroke needs to be handled, so on and so forth. So that's going to be interesting to see because as it creeps into the OR, where typically the people in the OR tend to be very detail-oriented in their respective fields because it's such a high-risk process which is going on. And how do you deal with AI? And how do you figure out when is the AI doing things properly versus making mistakes? And what do you do when the AI hands it off to the human operator at some point? So in many ways, everyone will have to adapt to AI as it's getting deployed. We can probably learn from some of the other domains like this is especially true with civilian pilots. Almost the entire plane can actually take off and land all by itself today. But yet there are times when the AI cannot handle it and the autopilot will hand it over to the pilot. And often we have had accidents during those times because the humans are rusty at that point. So as automation and AI increases, we're going to kind of face that problem, how to interface with the AI systems. They're going to make things far more safer, far more predictable, but interfacing with AI systems is hard for humans.
Thank you very much, Shyam, for joining, and thank you all of you for staying for such a long time. Our next session we are planning is on fetal interventions, and Devnath Chatterjee is going to talk on that, and we'll also have Professor Abraham from Amrita Institute to join us. So do join us again for the next episode of Marvelous Medicine. Till then, stay safe. Good night.